recheck them in a year because there will be progression, okay? And so some dogs never progress out of B1 and some absolutely can progress all the way through to C at some point, so that you just don't know what dog you have. B2 dogs are dogs where the stretch has gotten to a point where it's significant enough that these dogs would benefit from medication. We have large-scale studies that say that, and so the meds don't help the early dogs, they only help this middle section. And then the C dogs are dogs that are in or have been in heart failure, okay? So for that particular condition, you wouldn't need any specific medications for the heart at this stage with the B1, but the heart should be rechecked again in 1 year for progression. So that's that.
So is what Dr. Bell does with the Holter, does that have anything to do?
No, not for this disease, yeah. Now, I think probably where that was coming in is, my guess is that she went over to Bell because of the heart rate that you're observing in the evenings. Is that why you went over there? Or the breathing, the rapid breathing?
No, it's because when he was at Metro, they said that this was impinging on his vena cava and he should see a cardiologist.
Okay, fine. All right, so there would then, if that's the thought process, there's really nothing to do with the Holter regarding that. I can circle back to that in a second and maybe make some connections.
All right, and at least, I mean, I'm pretty emotional through all this.
Sure.
I think I'm giving you the right information.
No, you're fine.
Okay.
You're fine. Okay, so that's that particular. I'm just going to we're just hitting on the things that we know. Okay, so
Yes.
and also it doesn't sound like you've gotten good education on some of these diseases at this point. Okay, so that's the B1 heart disease. We would not need to do anything else with that right now for another year. Okay. Now, through the urgent care service here, you were diagnosed with pancreatitis, and we are definitively not managing that correctly. And that could be, and that's a significant disease. So we're going to talk about that disease extensively now. So your pancreas comes across and down your right side. It has two jobs. It makes digestive enzymes and it makes insulin. Most of the organ is dedicated to making digestive enzymes, but spread throughout, there are nests of cells that make insulin. Those enzymes are made and stored in the pancreas in an inactive form. They're on the shelf, they're waiting to be used. When you eat a meal, they get dumped into the intestines, they get mixed with the food, and then they get activated. And they're not smart. Once they're turned on, they just chew up what sits in front of them, which in theory is the food. With pancreatitis, those enzymes have been turned on in the organ itself. It is a digestion of your own organ. And you can have a pocket of inflammation and the whole thing can be trashed. You can have a titch of pancreatitis and you can die from pancreatitis. It runs the gamut, okay? That diagnosis is not...
You have a what?
Titch, just a little bit.
Okay.
And that, yeah, so it runs the gamut. There are two clinical forms. The one form is acute. Those dogs are really sick, vomiting, diarrhea, sick. They don't want to eat. And then there's a chronic active form where those dogs kind of fester along and they may have a waxing and waning appetite. They can break with a little bit of GI signs throughout the year, but often not that bad, okay? And it just depends. There's not one set way that they present. That diagnosis is not equivocal. It was definitively we have pancreatitis, okay? That's also probably partially responsible for some of the historical liver enzymes as well because of the regional inflammation that happens. The liver lays up against it. The only thing that's been proven to reduce the severity and frequency of pancreatitis is to feed a prescription low-fat diet. You have to stop all supplements, treats, peanut butter, pill pockets, cheese, nothing for joints, no omegas, no oils, no nothing. If you give fat in any form to this dog, oils or fats, it's like dropping a kerosene bomb on the pancreas. And so we're giving fat in all kinds of ways right now, okay? And there's more to the story. Steve would be far more sick outwardly if he probably doesn't have this adrenal piece too, okay? And the adrenal thing I'm going to talk about in a second, but it is probably masking. If you didn't have that piece, you probably, this dog would probably not be eating at all, would be my guess. And so it's incredibly important. They recommended it through the urgent care, but the diet that you're feeding is not appropriate. You got to stop all the joint stuff. You got to stop all the treats. You got to stop all that stuff. And if you don't get really, really serious about that, this is a dog that's, not only is it affecting the day-to-day quality of life, this is a painful disease. If you don't settle this down, it makes them sick and nauseous and they don't feel good. And it absolutely could be contributing to breathing and its heart rate changes and things like that. Pancreas will do all of that. And that is probably one of our biggest therapeutic points that needs to happen. But if you don't get it settled, this is a dog that can become diabetic. If you damage enough of your pancreas, then you can't make insulin anymore. You take out that organ, basically. So,
excuse me, doctor, did
yeah.
you say how far along, what stage this is?
Well, pancreas isn't really staged.
Oh, okay.
But we had the diagnosis back at urgent care.
Okay.
They ran a test in-house that was not even close to equivocal. It was very, very high. And so that's a known diagnosis. So lots of work to do on that. The good news is that right now we are not feeding a low-fat diet. The ones that are frustrating are the ones that come into us that are already doing it all right, and the dog is still struggling, because there's not a guarantee that every pancreas case is going to settle. But right now we have no reason to settle. We actually have every reason to be progressive with that. So we can clean that up, and that's easy. Then we move on to the other concern, which is an adrenal mass. And it's not clear in the paperwork. So when you first went into Metropolitan and they did what's called a FAST scan, there was two different imaging things that were done. One is a FAST scan, which is often done off the emergency service, where the emergency clinician who has less training does a scan of the abdomen, and they're looking for big stuff in that moment, like free fluid, things like that. And in that FAST scan, they talked about a right-sided mass next to the kidney. They didn't call adrenal, but the adrenals live right next to the kidney. That would have been logical place. On the official ultrasound report that was performed, they said it was a left-sided mass. So I don't know which is true, but then the thing is that the right adrenal is the one that lives next to the vena cava, and typically that would be the one that would invade. So I'm not, in theory, the report that said it was left-sided would have been the more experienced operator on the thing. So I'm wondering if they just got confused, but they're different comments in the record. I suspect it's going to be right-sided because they're talking about vena cava invasion. Is it possible that a left-sided adrenal mass can invade the vena cava? Yes, but it's got to cross all the way over the abdomen to that side. The right one just lives right next to it. So my guess is that it's right, but we're going to have to sort of figure that out. Obviously, that's important. But let's assume for a minute that it's a right-sided adrenal mass. Let's assume it's just an adrenal mass. It doesn't really matter, and it's an adrenal mass that is invading. Adrenal tumors can fall into a couple different categorizations. So first of all, you can have cancerous and non-cancerous adrenal tumors. So non-cancerous adrenal tumors are benign tumors that they're not going to spread to other locations in the body. And cancerous would be ones that would spread. So what are the differences? So you can have carcinomas, adenocarcinomas, and pheochromocytomas. Those are the big three. Those are cancerous. So carcinomas, and the reason that they're different categories, carcinomas arise from a different section of the adrenal gland. Adenocarcinomas come from another section of the adrenal gland, and then pheos come from the third section. Pheos can produce adrenaline, and I suspect that may have been why. Who gave you the carvedilol? Was that Sarah, Dr. Bell?
Mm-hmm.
Okay. I suspect that's why she did that, because she thought perhaps the adrenal tumor was a pheo. And so that's those tumors can dramatically and randomly dump adrenaline into the body, which can cause heart rates to just get really, really fast, randomly. And I don't think we have proof of that at this particular moment. I don't think anybody's ever captured one of those episodes, but I suspect that's why she did that. And that was the tie back to that particular drug. And potentially the reason that a Holter could be discussed in that moment was that she might have been thinking, well, because it's an episodic nature with the adrenaline dump, a Holter gives you a recording for 24-hour period. So that might allow you to capture an episodic component to that. That's the way I get there. Okay. All right. So, but pheos are incredibly rare. They're not common, and I don't know that we have a compelling case for this being a pheo. It is more likely to be one of the others. So you had carcinoma, adenocarcinoma, and pheo, and those are on the cancerous ones. The non-cancerous would be adenomas. Those are they're not going to spread. I would not expect an adenoma to invade into the vena cava per se. That, to me, that's a little. They usually tend to stay in their capsule, and they can get big, but they don't tend to grow into things. That, to me, is a more invasive characteristic. Now, beyond the cancerous and non-cancerous, there's another way to classify these, and that is functional and non-functional. And what that means is functional means they're producing things that hormones. So in the case of FeO, they can produce adrenaline, okay? But carcinomas, adenocarcinomas, and adenomas can be functional in producing things like cortisol, and this gets to the Cushing's concept. So Cushing's dogs have an excess of steroids in their body, and that causes all kinds of other side effects, okay? So cancerous and non-cancerous both can be functional and can be non-functional, okay? Does that make sense? Okay. And so a Cushing's dog will, if you're looking at them in a vacuum, there's things that you can see and there's things that we have to look for. So dogs with Cushing's are predisposed to, they'll drink more, they'll pee more, they'll pant for no reason, and it's intermittent in nature. They usually have an increased appetite. However, in this dog, the appetite may not be increased because pancreas is already going to pull you down. Cushing's may pull you up. Does that make sense? And so that actually may be keeping the appetite more consistent. What some people will actually say is one day the dog is ravenous and will eat you through whatever you put down, and the next day the appetite's picky. That's actually far more common because Cushing's it depends on who's winning, pancreas or Cushing's in that day. Does that make sense?
Yeah.
And so again, if you didn't likely have a functional piece to this, the pancreas probably would be front and center. Your dog probably would not be eating and you'd be in the hospital. Does that make sense? But because the Cushing's is likely there, and that's also strong evidence to point towards this not being an adrenaline-producing tumor, a FeO. It's more likely to be a cortisol-producing tumor because that's propping up the appetite. Does that make sense? Okay. Other things that Cushing's can cause, it predisposes to liver tumors, gallbladder disease, pancreas, hypertension, so high blood pressure. It predisposes to what's called silent UTIs. So that means the dogs show no clinical signs, but if you culture them, they will grow. So whenever we think a dog has Cushing's or no, we do a blood pressure and urine culture. It also does increase the clot risk. So clot risks are additive in dogs. The more risk factors you have, the more likely it is that you could develop a clot. So cancer is a risk factor, pancreas is a risk factor, Cushing's is a risk factor. So you start to add some of these things up and you can definitely get blood clots right in that area. So I've seen that before. So the tumor grows, it invades a little bit into the wall of the vena cava, and then you get a blood clot that forms, okay? How do you tell that? Well, if it's truly a tumor invading into the vena cava, then you'll see a continuous nature of it, and there'll be blood supply throughout that structure because it's a tumor. If it's a blood clot, then you might see sort of a start-stop to the tumor. It might come up and compress and be right up against the cava, but then a structure that's in the cava itself does not have blood supply to it because it's a blood clot. It's not a living thing. It's sitting there stuck, okay? And we can determine all that with imaging as long as we can see that. There really weren't any comments from Metropolitan about that nature as far as whether it had blood flow or not and things like that. So I don't really know. Now the challenge is that having an adrenal tumor, whether it's invading or not, it's not a good place to be because the surgery to take those out, it comes with a minimum of 50% mortality.
I did hear that from the doctor at Metro.
Yeah, and in my experience, it's been much higher. If you look in the textbooks, they would say if you have an adrenal tumor, you're supposed to take it out. That's what they say in the literature. And I actually don't recommend that because I've lost too many dogs over the years. And they are all cases like this. They usually have an endocrine component. The dogs may be sick for other reasons. They're not the healthiest of animals, but they're not dying. Yeah. And it's really difficult to swallow taking a dog to surgery that has life left and then losing the dog within 2 to 3 days. It's not necessarily the surgery that kills them. I lose them in the post-operative period afterwards. So that can happen. So now, but if you don't take it out, so in the case of a FeO, in the case of cancer that hasn't spread, you're leaving that cancer in the dog. Does that make sense? In which case, then that's not ideal from a cancer perspective, but you're just balancing the issues. Does that make sense? You could do, so the way that Cushing, if this tumor is functional, then we can work on the functional side of things. So you can diagnose functional Cushing's with a blood test, and then you can treat functional Cushing's with medication. What that does is it will decrease the clinical signs related to the Cushing's, the functional piece of the Cushing's. There's two ways to treat Cushing's. One is a drug called Vetoryl, and it is it's given twice a day, and what that drug does is it blocks the dog's ability to make the extra hormone. You need some steroids, you can't have none, but you don't want the extra, okay? And so that drug does nothing to the tumor itself, it just blocks the ability for the tumor to do this extra production, okay? But then you mitigate those side effects, and the dog's Cushing's complex can improve dramatically and all of that. So you can work on the heart doesn't need medicine. You got all kinds of room on the pancreas that we need to work on. And on the adrenal mass, we can characterize what side it is and whether it's a clot or invasion into the cava, and you could potentially do the test for Cushing's, diagnose it, and treat it. Yep.
Would you start that part again?
Yes. So if we're summarizing, so for the heart disease, we don't need meds, okay?
We don't
No.
need the carvedilol?
So I don't think we do. I think we can wean and come off of that, okay? I understand the thought process there. Dr. Bell was trying to sort of cover in case it was, I think she was thinking it was maybe a FEO potentially, but I don't think we need that. The pancreas, you have all kinds of ways we need to fix that, okay? And most of it is taking things away. These dogs can't get anything. Don't ever be impressed with how small of an amount it is if it's not appropriate, okay? And fat and oils in any form it's like dropping a kerosene bomb. And we have to get really serious on this dog, on this issue. And then on the adrenal mass, we can characterize a bit more as to, let's figure out if it's left or right, is it invasive, is it a clot, those kinds of things. I'm not gonna recommend taking it out. I think that's a bad idea. So my focus then becomes, well, do we need to control the clinical signs? Do we go after Cushing's, the functional piece of this? And you can do a blood test, a test for Cushing's, and if we're positive, then we can talk about treating it. And the challenge is if this is a tumor that's invading and or a clot that's coming off of that partial invasion, that's there, that could go from 0 to 60 at some point, okay? And if the vena cava is the largest vessel returning blood through your back half of your body, so if we start to get compressive to the point where that blood can't get past, that's going to cause fluid to leak into the abdomen, and that's going to become a stopping point very quickly.
So how can you tell when that might be approaching?
If there's fluid in the abdomen, yeah.
Well, but how would we know?
Ultrasound. You would start to see abdominal distension. Today we would ultrasound to put it to bed, this issue left, right, and whatever. But you would start to see, the dogs don't feel good. There would be a clinical response, like he would start to not feel well, but you also might see belly distension or even edema in the back legs, at the back half of the body, basically.
Okay.
The other thing that can happen is if it is a clot, or if a clot develops in the future, let's say it's not a clot now, but maybe a clot does form, it can break off and get shot up into the lungs, and they can get a pulmonary embolism, and they can go from I'm okay to I can't breathe, like that. So there are ways that, at some point this will become a very obvious problem and could very quickly go from we're okay to we're having to euthanize. That absolutely can happen on you and this dog. But my goal would be to control what we can control, treat what we can treat, keep the dog as comfortable as possible. I can't change the circumstances of that lesion, but we can do better to mitigate the clot risk. If we decide that we want to, the decision to try to diagnose the functional aspect of the tumor, the Cushing's possibility, none of that's wrong to do. It's just that the test takes like 3 weeks to get the results back, and then treatment takes a minimum of another month to sort of get stabilized. So now we're like a couple months into this process, and you could spend all that money and do that, and it's not horribly invasive for the dog, so it's really more of a financial thing. But this may come to a head before then. You are on the clock. I don't know how much time we have on this. This could go on for 6 months. This could become a problem tomorrow. I don't know that. And so you would have to go into that workup and that thought process with the idea that we don't know how much time we're going to have, but we're going to start plodding away and ticking the boxes that we can control. And if something happens before we can get there, then that's what it was meant to be, I guess. But does that make sense in terms of approach?
Yes.
Yeah. So in terms of what I would do today, certainly an ultrasound. That needs to happen. So we need to figure out the situation. Is it a clot? Is it right? Is it left? How bad is that pancreas? All that kind of stuff. When was the last time blood work was done, CBC chemistry? Do you remember is it a couple weeks ago, 3 weeks ago?
God, I wish I could remember.
Do you remember who did it?
Dr. Brown.
Brown did it, okay. Steve, go to Steve real quick and pull it up. I'm just trying to figure out if I need to. So I have CBCA, there it is, I have labs, okay. Well, so it was April, yeah, we need to do numbers today to see where we are. It's been about 5 weeks, almost 6 weeks.
Okay.
So.
He does not like to have his blood drawn. He doesn't like needles of any kind for any reason.
Yeah,
But-
I promise he'll be okay.
Okay.
Yeah, I don't either, but
You like?
I said I don't either.
Oh,
Yeah.
well, no, I don't
Yeah.
either. Probably not as badly as he doesn't.
So I would do blood work, I would do the ultrasounds. I'm assuming Belle did a blood pressure. She would have almost had to have, that would have been crazy for her.
She
not to.
did, yes.
Yeah, let me just make sure that wasn't high.
It was one of those Doppler things.
Yep, good.
And Dr. Brown had done one shortly before that as well, but just not the same kind. So I guess that was April as well.
Yeah, okay, no, that's fine. So she's saying, so you went in, who put you guys on the Carvedilol, Brown, or Belle?
Dr. Bell.
But she says continue the Carvedilol. Were there visits before this visit on 325? This is implying that Steve, so how long have you been going to Belle?
A year.
Okay,
Steve was here a year ago. Apparently somebody put it in as this March.
that may
But all
be part of
this
the
started
reason
a year ago.
my brain is in the wrong spot. So how many times have you been to CBCA?
Three times. First for the consultation, or maybe at the same time she did the Holter, I don't know. I think we went back for the Holter at once and then the Holter a second time. So.
Okay. Yeah, so they only, when they sent us records, they only sent us one set. That's why I thought there was only one set.
What is going on with this shit? Nobody can get anything right. I don't mean you, but.
It's okay, we'll get it. So that it's not a problem, and so that means, so in her notes, so let's go back to, try to remember back to, because this adrenal stuff was more recent, right? That was,
The adrenal stuff was a year ago. A year ago, I came here
okay.
with that in
I was
March.
thinking that was this last March.
No.
Okay, so this
In
is,
March,
so,
a year
so,
ago.
so what's driving you to pursue here now?
Rapid breathing,
Okay, so that's a change.
yes.
Okay, I'm thinking March, I'm thinking all of this happened at the
Yeah.
same time.
I'm sorry, I'm losing patience because of the incompetence
Yeah.
of relaying the information. When I called here,
Yeah.
I told them that it was because of rapid breathing that had
No,
started.
that's what my
in
understanding
February.
was, but I was
Okay.
trying to understand, so going back to March of last year, we did not have the rapid breathing, or we did?
We did not.
Okay.
That just started, my other girl dog was sick.
Mhm.
She died February 8th.
Okay,
At that point, I was paying a lot of attention to her, so
Right.
I don't know if he started it then.
Okay.
He has started this within that time period.
okay,
the
all
couple
right,
of
that
months.
makes more sense then, okay.
But I
Then-
also asked everybody to send all of the information. I asked them to send the
Yeah,
other site's information,
It happens
CBCA.
every day, it's fine, don't stress, don't
Well,
be
it's,
upset.
really, it's not fine with me because it seems like it's,
Yeah, we
Not
deal
fine.
with it every single day, so I will, I have the most recent cardiac evaluation from 325, I don't have anything
this
before
year?
that, yes.
Yes.
So I will,
25.
and that's where my brain was
I
thinking this
get
is all in
that.
the last few weeks, so.
Right.
Okay, alright, so, got it. And so has anybody in the last 5 weeks did Belle do chest x-rays? She did. Did she do chest
I think
x-rays?
she did an ultrasound.
That's what I thought so
Oh,
too,
she
but
did
I
an
have,
x-ray as
I have
well
x-rays,
before
yeah,
that, yes.
I'm just trying to make sure these are all at the same time. Or this is the most recent visit to CBCA, yeah, okay.
Dr. Bell also saw something tubular in his stomach, so when I went in to help with
Uh-huh.
the ultrasound, she said he's fine except he's got bones in his stomach.
Okay,
He doesn't have bones, I mean, we talked about this and she realizes they're not bones. He doesn't get bones.
okay,
She said it's something tubular,
sure,
but
okay.
he doesn't get anything unless it's a stick. But he doesn't usually go for those things either.
Okay.
So,
Well, I mean, we can see if we see anything on today's ultrasound. stomach is one of those organs, if it's gas filled, then you can't control this. Sometimes the stomach images really, really well, and sometimes you can't see a whole lot because there's a lot of gas interface. So we'll see what we can see.
Oh, it was gas tubes.
Yeah, well, no, the gas wouldn't cause the tube. I mean, she would have not commented on it unless it was a structure.
Right.
But I can only evaluate the stomach really thoroughly if there's no gas in it. So you could ultrasound and say the stomach looks normal, but you could still miss some of the contents and things just because of that. So we'll see.
Well, he had breakfast.
Okay, we have to work through that all the time. So we'll see what we can find on that.
Do you feel like he is uncomfortable?
He absolutely could be with his pancreas. I mean, yeah, it's hard to say, but you always assume that these dogs are painful or nauseous, whether the owners appreciate it or not. So definitely needs to, we absolutely need to get that squared away. That's a huge day-to-day thing. And it could affect the breathing too, and it could affect the heart rate. So we'll have to see. So yeah, so we would do blood work and an ultrasound. I'm quite confident that she did a blood pressure and that was fine, otherwise she would address it. We probably, because there's a year history, we're probably not going to take the beta blocker away. Probably keep the Carveta low, because that changes my perspective on that. Okay. So keep that. That's not hurting anything. I'm not sure I'm not sure if we're treating what we need to treat with that, but I don't want to take it away because she's commented on, and I need to get the original record because she said that Steve had a supraventricular tachycardia, which means the heart rate was fast. That doesn't mean that's a pathologic rhythm. You can have a fast heart rate for lots of reasons, and but when this last recheck was performed, the heart rate wasn't fast. So so for that way, at least the beta blocker is potentially working. What we were missing in that evaluation was there an underlying cause for the fast heart rate to begin with? Does that make sense?
Yes.
And that could tie to the adrenal gland. We've talked about how you get there. But again, I lean away from that adrenal tumor being a FeO, an adrenaline-producing tumor, and more likely into the other hormones, the carcinoma, adenocarcinoma, or adenoma, because I think that if there has to be a steroid influence in this dog, because I think your pancreas would be much more front and center if you didn't have that piece propping up the appetite. That's my guess. So we'll see.
All right. I'd like to tell you he has, that I know of, 3 other tumors. One small one on his chest, one large one on his side, and one I can't really discern on the inside of his, I think, left hand leg.
Okay. And are those changing in size? Have they been aspirated or anything like that?
They have not been aspirated.
Okay.
The one on his side has gotten larger since I noticed it.
Okay. Okay. So no one can tell you what something is without poking a needle in it. We don't poke needles in every single thing on every single dog.
Good.
So it's just up to you if you're concerned on that front or not. I think we evaluate the other issues. The other test that we would consider would be the Cushing's testing, and it's called an adrenal panel, and that is, it goes to Tennessee. It takes like 3 weeks to come back. It's not
And
fast.
it's a blood test?
Yeah, it's two draws. You have to, it's an hour apart. You get a baseline. You give the dog a stimulatory hormone, which causes the adrenal to make hormones, and then you do a post. A normal dog has some steroids, and then will go up. A dog with Cushing's usually has an elevated baseline, and they go way up because they are ramped up to make hormones.
But it's not going to harm him.
No, nothing. There's nothing here that harms him.
Sounds bad.
No. It's the same hormone that's already in his body. We're just giving a bump of it in that moment, so they do fine. And the only other thing that I can think of right now that makes sense is to do a urine culture. And the reason we do the culture is every dog that we think or know has Cushing's, 50% of them have silent UTIs, which means they don't have straining, they don't have blood, they have nothing.
And I was going to bring the first from this morning, but he saw a bunny and chased it out in the
Sure.
yard. I do have some in the car that I
We
got
would take it
after he.
sterilely. Yeah, that's called a cysto. So, but that's no big deal. We do thousands of those.
Tell him that.
I know. I promise. I mean, we're just trying to make him well. So
I know.
Yeah.
I know. I'm just trying to protect him too.
Yeah, that's okay. I mean, today's not a horribly invasive day. It would be he's going to have 2 blood draws, and urine would be taken. And then we use the same size needle we use to draw blood to take it from the bladder. So never had a problem before, knock on wood. And it's ultrasound guided, so you know that's how it gets done.
Which one is ultrasound guided?
The urine collection.
Okay.
Yeah, the blood draws just regular blood draw.
Of course.
Yeah. So what I can do is build you an estimate. If you're okay with costs, then I need some time, probably about 3 hours about to do what we need. The blood draw is, the adrenal test is about an hour, but he has to go into the queue for the imaging, and
You need him for 3 hours?
Mhm.
Oh Jesus, what am I gonna do?
I don't know, whatever you want.
Go with him?
No,
No.
you don't get to go with him.
Oh, shit.
Yeah.
Okay.
Let me get you numbers,
I'm
and then you
okay
can
with the
decide.
cost.
What's that?
I'm okay with the cost.
It's okay, we don't have we have a policy, so we get estimates and just say everybody's on the same page. And it also, once the estimate is agreed to, then it goes into the system and all that kind of stuff. So let me get you the numbers. If you're okay with the plan, then we'll go ahead and get things going. We'll bring you back as soon as we're done, okay?
Mhm.
Now, I will have the blood work, the ultrasound to talk about immediately today. I will not have the adrenal panel, the Cushing's test, that's a 2 to 3 weeker. The urine culture is about a week to come back. So there'll be a couple things that will be hanging and be out there, and then we will reevaluate and adjust the plan once we get those numbers back, okay?
Yes.
Okay.
And you will write down everything you have to tell me at the end, too.
Yeah, so everything gets written down, everything that we did, the disease processes that we've diagnosed, all of that. You won't have it when you walk out, because I have 30 cases and they don't come later today by email. But yes, I just need to be able to have time to sit down, and that way I don't miss things, and there's a lot to write.
Yeah.
And so, but yeah, it'll come by email later today.
All right, and will you all send it to Dr. Brown, or?
Yeah, Dr. Brown is in the portal, so we have a veterinarian portal, so she actually can see all this stuff lifetime.
Okay,
Whenever
what
she
about
wants.
Dr. Bell?
Bell's on there too, everybody
Okay.
gets in there.
Okay.
Yeah. I don't think I put Metropolitan on there, but I can certainly
Who
include them.
cares?
Okay, yeah.
Piss on 'em.
No, I mean, they do a good job. It's just it's a difference of having a criticalist. Dr. Smith's a criticalist, and he does a good job. But this is a dog that really needs an internist, I think, because of the disease processes that you have. You also need a point person to coordinate some of these subspecialties. So,
Yeah.
Bell's important.
Sure, it makes sense, but he was there for 4 days. It seems like they could have at least given you the correct information after that was over with.
Well, I think there's just we have all the information, there's just confusion between the fast scan. So one doctor did the fast scan, one did the ultrasound, and they're one saying left, one saying right. And so somebody's wrong. I don't know, it's either the left or the right.
Yeah.
And,
I'm sorry, I came in pissed off. The first experience I had here was horrible.
okay,
And so it was like PTSD coming back, bringing Steve in again.
sure,
He was good with it. I thought maybe he wouldn't even want to come in.
sure.
But it just, it just seems like people can get their ducks in a row and report things accurately.
Yeah, I mean, there's always a chance. I think everybody tries real hard. And it is, I mean, there's a lot. I wish I was perfect every single day. And, I'm sure you can pick apart what I end up doing today, and there'll be some nuance there. We try real hard. I am not perfect,
I get that, really, I get that.
Yep, that's all we can do.
I'm just over it, there's a conglomerate of stuff that happens, it seems, it just builds up.
Yeah.
So anyway, I'm sorry.
Okay.
Just
Well,
let
I
me
guess
know my
my thought is let's just sort of put our head down and it's a new day, and let's figure out where we are, and we'll go from there, and let's not let previous experiences, jade us for what we're doing forward, and we'll figure it out.
No, as long as you let me blow off a little, I'm good, thanks.
Okay.
So, well, we'll talk about it when I come back. What time should I come back? Or do you know yet?
We'll text you when we're
Okay.
done. Yeah.
You will?
Yeah.
So, well, I'm like downtown, so I'd
Yeah.
like to be in the area when it's.
That's fine, but it's gonna be about 3, I just can't commit to an
Okay.
exact time, I will
Okay.
disappoint you. It doesn't feel busy, but
Uh-huh.
there are probably
I-
45 cases in the back right now.
Holy.
Yeah, there's a lot, owners don't get to see that side of it, cause we have like 15 to 17 that get dropped off first thing. They're all unfortunately just as sick as Steve is on paper with that collection of problems. And I have to sequentially, very structurally, myself and Clark and the other doctors go through to make sure we don't miss things. So,
Yeah, good, I'm glad you do that.
yep.
The
but
parking lot was full when we came in.
Yeah, those are just those are the ones that are being received for appointments. That's not the ones that were already there. The ones that were already there
Dropped off.
came.
The ones that were dropped off.
Mhm.
Mhm.
Yeah, so there's a bunch. Let me get you numbers, we'll get things moving, okay?
Thank you.
Alright, thank you.